Thank you again for the Latin American and Caribbean chapter of WADM for inviting me. I just want to note I have a presentation done exactly the same time last year, June 26, 2024, talking about climate change in the Caribbean. And I'm happy to present this presentation because it is timely. It is hurricane season on hurricanes, health systems, and human survival, and how we can strengthen resilience in the Caribbean. So we're going to explore the intersection of hurricane-related disasters, climate change, and health system preparedness in the Caribbean. It will examine how increasingly intense hurricanes are straining public health systems and what disaster medicine professionals can do to adapt and mitigate future impacts. Drawing from real-world experiences, including the response to hurricanes in the region, this presentation will highlight lessons learned, equity challenges, and practical approaches to improve hurricane preparedness, emergency care, and post-disaster health resilience. So, our objectives is first, we will review hurricane trends in the Atlantic Basin, the impact of climate change has on hurricanes and the health-related complications. Next, we'll look at real cases from across the Caribbean, including Irma, Maria, Dorian, and lastly, Beryl. I hope to conclude with practical recommendations that can help clinicians, emergency managers, and policy prepare more effectively for climate-driven disasters. So this timeline clearly illustrates the increasing intensity and frequency of devastating storms in the Caribbean region over the past 2 decades. From Hurricane Ivan's catastrophic economic impact in 2004, through the multiple destructive hurricanes such as Sandy, Matthew, Irma, Maria, and Dorian, we see a clear and alarming trend. Each event underscores the urgency of strengthening our regional preparedness, building resilient infrastructure, and enhancing disaster response capacities to safeguard communities and healthcare systems from increasingly severe hurricanes. Now, climate change is not a distant threat. It is here. It is already transforming the characteristics of tropical cyclones. Warming sea surface temperatures give storms more energy, making them stronger. At the same time, many hurricanes are moving more slowly, which increases the duration of exposure to wind and rain. Combined with sea level rise, this leads to more intense flooding and storm surge. While the overall number of tropical cyclones may not increase significantly, there is evidence that suggests that the proportion of intense hurricanes could rise in a warming climate. And this is important for Caribbean nations because we are small island developing states, highly exposed to climate change, with roughly 70% of our people living in coastal areas where storm surges and floods hit first. Islands like my home country lie only a few meters above sea level and are in Hurricane Alley. Climate models project Caribbean climate damages rising to greater than 20% of regional GDP by the year 2100. So basically a little over 70 years. In short, without urgent adaptation, intense storms will increasingly threaten health infrastructure and populations in the Caribbean. Now, when I talk about Hurricane Alley and Hurricane Belt, Hurricane Alley generally refers to the specific region in the Atlantic Ocean where hurricanes frequently develop and travel. This area typically stretches from the west coast of northern Africa to the east coast of Central America and the Gulf of the southern United States. It's essentially a corridor of warm waters where hurricanes can gain strength and intensity. The hurricane belt encompasses broader areas where hurricanes are more likely to occur. So in essence, Hurricane Alley is a subset of the broader hurricane belt, specifically the area within the Atlantic where hurricanes commonly form and move. Unfortunately, as you can see in the slide, for us, the Bahamas, we are located within the hurricane belt and sit within Hurricane Alley, making it particularly vulnerable to hurricanes. Several other islands, such as Barbados and Dominica, also lie inside Hurricane Alley. This leads to the high vulnerability of several Caribbean to hurricanes, as indicated by the Tropical Cyclone Exposure Index. Countries such as mine, Antigua and Barbuda, Cuba, Dominican Republic, and Mexico show significant exposure, underscoring the urgent need for comprehensive hurricane preparedness and robust resilience planning. Recognizing these risks helps us better target resources, enhance regional cooperation, and protect communities most at risk. So as stated, hurricane season begins June 1st and ends November 30th. Peak hurricane activity is usually seen late August to October. However, with the warming climate, especially sea surface temperatures, storm activity has been seen as early as April and as late as December in the Atlantic Basin. In July 2024, Hurricane Beryl was the earliest Atlantic Basin Category 5 hurricane on record to become the strongest hurricane on record to make landfall in Grenada and other islands in the southeastern Caribbean. So normally for us, our healthcare system usually tends to start planning for a hurricane season early February to March. And we begin monthly and then weekly. And usually this is basically all departments in the hospital and also the clinics. We get together to determine what needs to be done to make us hurricane ready for the season. And generally for us clinicians, we set up our hurricane rosters for physicians and nurses and other auxiliary staff that will have to be in hospital during the hurricane and those that are going to respond after the hurricane. Now, this next slide, this is a slide that in the last couple of years when I present the Grand Bahama experience for Dorian, this is a slide that I always show because of this important slide. This slide actually shows significant hurricanes that had made landfall in Grand Bahama and had significant impact on our healthcare system, the Ryan Memorial Hospital, from almost 20 years. So since 2016, there's been at least 10 Category 5 hurricanes. So important to note in some history of hurricane names, in the 20th century, the US referenced time periods. In the West Indies, we used saint names. But in the 1950s and 60s, this is when names became in fashion to use. And initially it was women names, but because of their destruction, the feminist movement took issue with this. And so this led to the current alternating of male-female names, and the list is recycled every 6 years. When the names have been exhausted, the Greek alphabet was used, which occurred in 2020. However, the World Meteorological Organization in 2021 introduced an alternate list of names due to challenges with the Greek alphabet. Last year's Atlantic hurricane season had an above average number of storms, with 18 named storms compared to 14 that was happening between 1991 and 2020. And it's important to note that when a hurricane has caused catastrophic damage, such as billions in damages and loss of life, the name is retired. So it's important to note that all these names that you see on this list have been retired due to the destruction they've caused. And it's important to note that every 6 years, this is year 6 since Hurricane Dorian. And so we're in our current season list is the same as 2019. And Hurricane Dorian, hopefully, we hope we don't see its replacement, has been replaced by Dexter. So hurricanes, like any other disasters, their health impacts are seen in waves. So initially we see the health impacts related to the impact from hazard effects. Then you have your aftermath, which is days to weeks, and this coincides with societal disruption. And then you see impacts due to the recovery phase. And then this moves on to recovery and then to long-term, which is basically heading into what is your new normal after the aftermath of the storm. So when we impose these phases on things that we can see during the times of a hurricane, immediate trauma, we noted due to high winds and flooding, and these cause injuries and fatalities. Crush injuries, lacerations, drownings and burns are common in the immediate. Next, you will see increased risk of infectious diseases from flooding and standing water, which facilitates outbreaks of waterborne and vector-borne diseases. Climate-driven flooding has been linked to spikes in dengue and other mosquito-borne illnesses. Shelter conditions due to crowding and poor sanitation also aid transmission of respiratory viruses and gastrointestinal infections. Disasters also release toxins such as sewage, chemicals, and mold, and can increase risk of leptospirosis and other infections. After Dorian in 2019, the oil refinery plant lost the caps off of storage tanks, and there was a significant oil spill on the eastern part of the island of Grand Bahama. Chronic disruptions leads to severely interruption of the chronic conditions of patients, and this is due to compromise to clinics and loss of access to providers. Storm damage to clinics and supply chains means dialysis, chemotherapy, TB clinics, HIV clinics, maternal child and health services may collapse temporarily. Hospitals and clinics may lose power, water, and supplies. And we saw this, of course, in 2019. Maintaining medication stocks and alternate care sites is essential to prevent long-term health deterioration. And then, of course, we must focus on our vulnerable groups, children and the elderly, especially persons with disabilities, the poor, and those in remote areas are disproportionately affected. Pre-existing disparities, such as limited healthcare access, mean that these groups suffer more both during and after the storm. For example, lack of transport and information exacerbates care gaps for remote or rural residents. Mental health, I put this separately because mental health is too often overlooked in disasters. Yet evidence show a large fraction of hurricane survivors suffer ongoing psychiatric distress. And it's not just the survivors themselves, but also the responders. About 15 to 20% may develop PTSD or severe depression. In the Caribbean, this burden collides with limited resources. Most islands have a severe shortage of psychologists and psychiatrists, and cultural stigma discourages people from coming forward. For instance, mental health services were overwhelmed during the recent storms. We must therefore bake psychosocial support into all phases. This means deploying counselors alongside medics in the immediate aftermath and training frontline healthcare workers in basic psychological first aid. In practice, we recommend community-based follow-up, such as schools and community centers hosting support groups and accessible helplines. Another key tool is telemental health. Even a phone hotline or an SMS check-in can help islands where clinics are down. Lastly, addressing the stigma through public education is critical. If we do this properly, survivors will get help before their distress becomes chronic. Next, it's important to talk about surge capacity. The WHO's benchmark of 4.45 health workers per 1,000 plus a 30% extra for disaster highlights how stretched our systems are. In fact, most Caribbean nations can barely meet everyday demands, leaving almost no buffer when a hurricane hits. To compensate, we rely on regional solidarity and mutual aid. We have mechanisms for countries to share health personnel across borders. For instance, PAHO and Caribbean militaries have run joint exercises to ensure teams can deploy quickly after landfall. Recently, Barbados health and military teams ran a live drill for a storm scenario. Another key resource is the diaspora and NGOs. After Maria, doctors from Dominica, then working abroad, returned home on their own initiative to treat 800 plus patients in a field hospital. Today, organizations like Direct Relief fund the Caribbean ambulatory response, team of volunteers, such as physicians, nurses, and support staff, ready to jump on a plane after the next cyclone. These search strategies, formal and informal, are life-saving. Moving forward, each country should formalize agreements, for example, pre-approved medical licenses and rapid customs clearance, so that in a crisis, reinforcements can arrive without bureaucratic delay. It's also vital to train local staff to operate in austere, high-demand conditions, ensuring that we can maximize these search resources when needed. So now we're going to look at some of the cases. So first up is Maria and Irma. These were the twin storms. Hurricane Irma first hit the U.S. Virgin Islands, then Maria struck Puerto Rico and the U.S. Virgin Islands 2 weeks later. The results were unprecedented. In the Virgin Islands, Irma was a Category 5 storm that obliterated basic utilities on St. Thomas and St. John, and all local dialysis units were rendered inoperable. In the immediate aftermath, hundreds of kidney failure patients were evacuated to nearby Puerto Rico for emergency treatment. Physicians noted high blood glucose levels in shelter occupants, as many diabetes and hypertension patients lacked medications. There was no formal epidemiological study cited, but providers reported a surge in NCD's complications requiring hospitalizations. And in Puerto Rico, Irma and Maria, due to catastrophic winds, destroyed many clinics and 80 to 100% of the power grid in areas. Nearly a year later, more than 200 of the clinics still relied on generators. Studies there documented sharp increases in new diabetes and hypertension cases post-storm, and many patients reported missing medications for weeks. The government and NGOs used mobile clinics to reach isolated patients, and PAHO airlifted shipments of medications and NCD kits to refill prescriptions. Nonetheless, many chronically ill Puerto Ricans faced deteriorating health and higher mortality in the months after Maria. And in Dominica, Maria literally swept away roofs on every house and clinic on the island. This meant chronic patients and the community clinics that served them had to rebuild from scratch. Local and international teams reported huge spikes in stress-related conditions. PAHO field teams emphasized rapid shelter and medicine provision to prevent NCD's emergencies. Next, of course, is Dorian. Dorian is tied with the 1935 Labor Day hurricane for one of the strongest Atlantic hurricanes ever recorded to make landfall as the most catastrophic in Bahamian history, with greater than $3.4 billion in damage. It arrived as a high-end Category 5 with winds of 185 miles per hour with gusts of over 225 miles per hour. We had king tides and storm surges of greater than 25 feet. It crawled over the islands of Abaco and Grand Bahama from September 1st to the 3rd. Structures that survived suffered significant damage. By official counts, there were over 70 fatalities with hundreds of persons missing. Approximately 70,000 people, which is close to a quarter of the nation's population, were left homeless due to the destruction on Abaco and Grand Bahama. Many lived in precarious settlements, and in such, these were persons who were undocumented who had feared being shunned or some type of legal recourse if they had sought shelter at the local shelters. And so Bahamians faced extra hardships due to this. Immediate health fallout was severe. Teams reported numerous injuries from flying debris, laceration and fractures, often treated in makeshift triage tents. Gastrointestinal illnesses were a concern due to contaminated waters. However, saltwater intrusion was a significant burden because it damaged pipes and appliances, and it took almost 2 years before the water on Grand Bahama to become potable. There was grave concern about mosquito-borne illnesses after Dorian due to the stagnant water, because it became a breeding ground for these vectors such as dengue and chikungunya. Many people with chronic diseases such as hypertension and diabetes suddenly lost access to medication and clinic care. So this increased the risk of strokes and other complications. In response, the Bahamas government activated its National Emergency Management Agency. Local clinics, hospitals that remained operational immediately reopened, often running 24/7 on generators. Within days, the Marsh Harbor Health Center, which had survived largely intact, was staffed around the clock to treat injured patients. International assistance came from many quarters. PAHO and WHO had teams on the ground providing WASH support and coordinating with the Ministry of Health. The International Medical Corps flew in emergency medical units, and they assisted us mostly in the clinics in the settlement. Another NGO assisted us with erecting a field hospital on the island of Grand Bahama so that we were able to perform, to see emergency cases, to house admissions, and to perform surgeries. And currently, what ended up happening to the hospital, like I stated before, half of it became flooded. So my emergency room became the hospital for most of the time. And so my trauma bay became the ICU, my ER bay became the ward, radiology suite became PEDS, NICU. And we were working out of that for a while. Next, Hurricane Fiona, a more recent example, struck nearly 5 years after Maria, dumping historic rains on Puerto Rico. And what's important to note why climate change is a factor is that when Fiona hit, Puerto Rico, it hit Puerto Rico as a Category 1. However, because of the slow movement of the storm, it dropped significant rainfall, causing severe flooding and landslides. Around 80% of the residents were without electricity for days. Unfortunately, many communities remain as vulnerable as in 2017, for instance. And one report noted that roughly 20% of Puerto Ricans who live with disabilities lacked strong social safety nets. In the weeks after Fiona, there was a leptospirosis outbreak, which is a bacterial disease spread through floodwaters. There was 156 confirmed cases, making it one of the largest leptospirosis spikes on record. Public health authorities had to act quickly. They made leptospirosis immediately reportable and alerted physicians to treat suspected cases early. On the policy side, federal and local governments did declare emergencies and take steps temporarily waiving maritime shipping rules to bring diesel for generators. Yet these moves were slower than ideal. Observers called Fiona a cautionary tale of red tape delaying aid. Fiona, we gleaned two lessons. One, anticipate secondary outbreaks after flooding, and two, streamline recovery management. For clinicians, we must remember that after storms, we must intensify outreach, check on dialysis and dialysis patients, and distribute clean water tablets and monitor for unusual cluster of diseases. And most recently, Hurricane Beryl, as again stated, occurred July 2024. It was striking in both its power and swiftness. It became the earliest ever Atlantic Category 5 hurricane, reaching sustained winds of around 165 miles per hour. On July 1st, it tore through the southern Grenadines, tiny islands off of Grenada, causing near total destruction. Government damage surveys found that roughly 98% of homes and buildings on Carriacou and Petite Martinique were damaged or wiped out. Entire communities literally disappeared from the landscape. Overall official reports counted 11 fatalities regionally. And like I stated before, sometimes reporting tends to lie with fatality numbers. While tragic, this is modest given the storm's ferocity. Largely thanks to aggressive evacuations and advanced warning, Grenadian authorities evacuated thousands from Carriacou ahead of landfall. Damage and displacement were also severe in other nations. Southern Jamaica saw flooding and power outages. St. Vincent's outlying islands lost all local services for days. Even northern Venezuela reported casualties. In Grenada, at least 4,000 homes were destroyed or uninhabitable on the main island, adding to the toll from Carriacou. Many victims were isolated, coastal residents, or fishermen whose boats and nets were lost. Healthcare was heavily disrupted. Direct Relief and PAHO reports noted that almost all clinics in Grenada and St. Vincent and the Grenadines either lost roofs or power, forcing generators and water deliveries. But what's important to note with Grenada and St. Vincent and the Grenadines had been part of the PAHO Smart Hospitals initiative. And even though they had suffered damage, they were able to quickly start providing care with challenge with roofing and also challenge with water. So that was significant. Why the power was a challenge is because vaccines in the National Immunization Program were at risk. Refrigerators and several clinics failed during the blackout. Emergency medical teams treated storm injuries. There were cases of eye injuries, severe lacerations, and fractures. However, unlike some slow-moving storms, Beryl's short duration meant it did not immediately trigger large epidemic outbreaks. Nonetheless, the days after Beryl, there were increased reports of acute gastrointestinal illness among shelter populations, likely due to sanitation issues, and relief agencies preemptively distributed oral rehydration salts and antibiotics. Many residents reported stress-related conditions and insomnia, common after severe disaster. Response benefited from early investment in preparedness. PAHO's pre-stocked medicines arrived just before landfall, and first responders, including Jamaican Red Cross volunteers, had emergency kits at the ready. Within 24 to 48 hours of the storm, field hospitals were set up using the tents and cots shipped in. For example, in Carriacou, the Ministry of Health and PAHO erected 2 large medical tents to serve hundreds of patients. Mobile X-ray and lab units were flown in from Trinidad, and the International Federation of the Red Cross and Red Cross Societies mobilized as well. Cash and care programs were launched, providing storm-affected families with cash assistance and hygiene kits. Government agencies reopened makeshift hospitals and clinics under tarps. So in short, Beryl, while causing catastrophic damage to infrastructure and property, the coordinated early response from local emergency services up to international relief organizations meant that life-saving care and supplies reached affected communities quickly. Ongoing challenges remain, however, such as rebuilding shelters and clinics, and this is a long process. but the initial emergency phase was handled with remarkable speed given the storm's intensity. So lesson learned from all of these was that these experiences underlying key lessons. First, pre-disaster planning must include NCD patients. That means emergency medical records, personal medication kits, and home backup generators where possible to keep devices running. PAHO recommends supplying WHO NCD emergency kits containing insulin, blood pressure medications, inhalers, etc., to affected areas immediately after storms. Mobile outreach is clinical. Puerto Rico's use of mobile clinics and volunteer health teams bridged gaps when static clinics were down. Authorities also expanded shelter health services to catch and treat NCD rise during the crisis. Second, mental health support should be integral. Disaster planning now often includes trauma counseling alongside medical care because it is bidirectional. It has a bidirectional impact on chronic illness control. Third, strengthening local primary care and supply chains reduces vulnerability. In the Caribbean, hurricanes disrupt every link in chronic disease management, from clinic operations and medication access to patient self-care, leading to worse outcomes for these chronic illnesses. Reports across the region have documented these effects and stressed the need for resilient health infrastructure and emergency preparedness. By restoring clinics and utilities quickly, deploying emergency medical kits, and integrating chronic care into disaster response, we aim to mitigate these impacts. Next, we'll also see that hurricanes often lead to disease outbreaks from basic needs being unmet. And especially this has an impact on our water. Each hospital healthcare facility must ensure clean water and sanitation are continuous. This may mean extra bottled water, portable water tanks, and redundant toilets. Communities must also avoid disease. We saw after Fiona a jump of leptospirosis, a preventable flood-related illness. It is recommended to position larvicide and distributing nets to prevent dengue as rain recedes. Food safety is often neglected. Health agencies should collaborate with agriculture to ensure food aid is safely stored. In short, sanitation and public health measures are just as critical as acute trauma care in the wake of hurricanes. Looking at recovery frameworks, our approach must be twofold. First, we must rapidly get health facilities back online. This often involves temporary solutions such as mobile clinics, tarps for roofs, diesel for generators. The WHO guidance confirms that resuming basic primary care and emergency service must be the first step in recovery. Second, we should seize the opportunity on that moment to build back better. This means system-wide improvement. For example, after Hurricane Matthew, PAHO helped rebuild not just hospitals, but also strengthen cold chain systems and training programs. The WHO's recovery toolkit lays out steps for exactly this, from leadership coordination to workforce training. It encourages us to use a primary healthcare approach, ensuring clinics in hard-hit neighborhoods get priority. Practical steps include fast-tracking procurement of new equipment, offering mental health counseling in clinics, linking rehab of health facilities to broader infrastructure plans like road building. And finally, we must stress inclusivity. In contrast to the slow federal response in Puerto Rico, recovery plans for future storms should already involve local health boards who can quickly identify their most urgent needs. This community-driven recovery will make our health system stronger and more equitable should the next storm occur. And I can't stress enough the PAHO WHO Smart Hospitals Initiative, which is a great model. It combines structural reinforcement with green technology. The smart health centers in Mandeville and Santa Cruz, while experiencing minor damage from leaks in Mandeville, were able to maintain functionality due to the upgrades. The solar power systems in these facilities continue to operate during power surges, providing crucial support for clinical services and the parish's Health Emergency Operations Center. This highlights the success of the project in enhancing disaster and climate resilience in the healthcare sector. Such successes underscores the point that most facilities are underprepared. PAHO notes that over 3/4 of regional hospitals are in the flood zones, built to old seismic codes that ignore climate change. So using the WHO's framework, we recommend retrofitting new construction to be climate resilient, strong storm shutters, elevated floors, cool roof materials, and internal layouts that can operate if one wing is underwater. Energy independence is key. Solar arrays with battery banks will keep lights and ventilators on. In short, when we're building a clinic or a hospital, we must incorporate flood defenses, alternate water sources such as wells or tanks, and efficient HVAC systems. Investing in these measures pays off when the next hurricane arrives. So now policy is our roadmap to the future. So globally, we already have the Sendai framework and international health regulations, which commit governments to disaster risk reduction and health security. Regionally, PAHO has catalyzed this action. The Caribbean's first health and climate action plan in 2019 to 2023 was built through cross-sector collaboration. This year, countries have gathered to update it, focusing on evidence and resources. One concrete examples of regional preparedness is the new PAHO Emergency Operations Center, EOC in Barbados, which opened in April 2025. This EOC will coordinate health logistics and information during hurricanes for all Eastern Caribbean states. At the country level, effective frameworks mean having up-to-date health emergency laws and budget lines. We should also strive to include health and climate policies. For instance, as PAHO advises, Caribbean nations should mention health resilience in their nationally determined contributions. Finally, resistance policies must incorporate financing, building reserves and buying insurance like the Caribbean Catastrophic Risk Insurance Facility, so that funds are readily available before storms. And an example in financing initiative is the Bridgetown initiative that came out in 2023. It was a proposal to reform the world of development finance, particularly how rich countries help poor countries cope with and adapt for climate change. And so that was an important initiative that came out of Barbados. So when we are adapting our policies or forming our policies, we must always ensure equity when developing them. Climate change disproportionately affects those who contributed the least, as stated. When the analysis was made, 41 million in Latin America and Caribbean live on the coast and only a few meters above sea level. In some islands, that's the majority of the population. Health infrastructure, too, is vulnerable, such as in Aruba and, of course, the Bahamas and other SIDS. 80% of hospitals are in these low-lying areas. Among persons, we must consider children, women, older persons, undocumented persons, and disabled individuals. After Fiona, NGOs reported that disabled Puerto Ricans were often trapped at home because they had no evacuation support. Women lost access to maternal health services. So to address this, resilience plans must have equity measures. For example, we can equip shelters and clinics with ramps and provide language interpreters. We can run targeted outreach to pregnant women and elderly after a storm. Crucial recovery aid, such as housing, livelihood assistance, should be distributed with priority to the most disadvantaged. By building trust with the community through local health communities and NGOs, we ensure that no one is left out of the preparedness and recovery efforts. And building on surge capacity, we need structured training and coordination. Caribbean nations should maintain emergency medical team rosters, just like the WHO's global initiative registers EMTs for earthquakes and floods. In practice, this means training volunteer physicians and nurses in emergency response ahead of time. All hospitals should have a written disaster plan, and staff should drill it annually. We saw in Barbados that a joint drill with police, fire, and health personnel improved readiness. And that's the picture that I'm showing there. And I just want to point out that my medical director of EMS is actually in that picture. So I'm happy to see that we were there for the training. Effective communication is key. Every clinic should have a backup communication plan, such as satellite radios if need be, in the event that cellular networks fail, as they did for us in Hurricane Dorian. Lastly, sharing knowledge is cost-effective. Continuing these networks through virtual workshops or regional conferences ensures that even small islands can benefit from collective experience. Risk communication saves lives. Before and during storm, governments through their Ministry of Health or Department of Health should broadcast practical health guidance. For example, ahead of a hurricane, remind residents to keep a week's supply of medications at home. After, radio and social media should quickly broadcast locations of open clinics and give boil water advisories. It's crucial to use trusted channels in many Caribbean communities. These are the church networks or local radio stations. These are more trusted than even official sources, especially in older persons. We also should engage communities in planning. In Puerto Rico, citizen advisory boards helped authorities understand neighborhood health needs after Maria. Similarly, setting up disease hotlines allows people to report illnesses early. This two-way communication improves both public trust and situational awareness for responders. Finally, resilience is a team sport. Health authorities should sit at the same table with disaster management, utilities, and urban planning. For example, when a hospital is built, ensure the roads to it will be passable in a storm by talking to transport planners. And in emergency, road access is critical. Communities must be empowered too. We have seen successful volunteer healthcare worker programs where locals help run clinics post-disaster. Churches and civic groups often know who the most vulnerable families are. Engaging the private sector is also smart. Pharmaceutical chains can commit to donating emergency drugs, or hotels can serve as overflow shelters. Regionally, we can continue to share resources. Organizations like SEDEMA should ensure health is integrated into all these regional drills. Resilience comes from the whole community, not just the hospitals. Continuous improvement depends on measurement. After a hurricane, a health sector review should be written. This includes how many patient visits did clinics see compared to normal? Did maternal health services drop? This data makes it clear where the biggest problems were. For instance, the Puerto Rico studies after Maria systemically counted storm-attributed deaths. We should replicate such analyses for every major event. Health ministries can issue simple spreadsheets for every clinic to fill out weekly during recovery. On the research side, local universities can partner on disaster health projects, say tracking any increases in vector-borne illnesses or looking at any increases in mental health appearances. The important thing is to turn research into action. If one island finds that having water tanks at clinics prevented outbreaks, that becomes a model for its neighbors. In practice, every post-storm review should end with action points. Exactly who will do what for the next time. This closes the loop of learning. So in closing, let's highlight our core action points. First, fortify our health infrastructure using the principles of smart hospitals. This will minimize service outages. Second, build surge capacity by training responders and leveraging the Caribbean diaspora while embedding mental health support into every plan. Third, implement the policy frameworks we discussed. Activate EOCs, align health and climate policies, and ensure our legal systems mandate these preparations. Fourth, finance it properly. Maintain the CCRIF coverage. They paid tens of millions after Maria, and pursue every possible adaptation grant. And my advice is all health members in every country should link with forces with your representative in climate change, who is a party member, so that when they go to the negotiating table, either at COP or at the UN, they can focus on health, give a better argument, persuasive argument, especially when they go into the rooms to negotiate in discussions for adaptation and especially loss and damages. And so that it effectively adds to international negotiations like the Bridgetown Initiative. Finally, equity must be a thread to all actions, protecting those at highest risk. With this comprehensive approach, infrastructure, people, policy, money, and fairness, the Caribbean's health systems can become far more resilient. Lastly, let us commit to gathering and sharing data after every storm. Only by learning continuously can we truly protect health in our warming Caribbean. I look forward to all your insights and working together on these strategies. And now, thank you. And any questions?
Latoya, thank you so much for that wonderful, comprehensive, and very thoughtful presentation. I know you probably would not have had a chance to scroll through the list of attendees, but it's nice to see so many familiar faces. and our mutual friend, Jamila, who's logged in today. Thank you for making the time. So we're asking participants to post questions in the Q&A tab. And while we give people the opportunity to do so, I did notice one of the recurring themes that you had throughout your presentation what was the role of international organizations such as the WHO and the PAHO. Could you just expand a little bit about your own experiences in disasters? How active were these organizations? Did that extend into the International Red Cross and Red Crescent, etc.?
So for us with Dorian, the PAHO WHO linked with the Ministry of Health in Nassau. So a lot of times they got their directive from what they were able to glean from us. So whatever our needs were, it was expressed to the Ministry of Health in Nassau, and they spoke with WHO and PAHO to determine what emergency medical teams we needed. So of course, like I said, in Dorian, we basically lost the hospital. And when I say lost the hospital, I was the administrative block, the operating theater, the wards, ICU, maternity ward, pediatric ward. So all of that was gone. So that meant then the only thing, like I said, functioning was the emergency room. And so the emergency room became the entire hospital. And so how they helped us was, yes, one organization set up a field hospital, that was Samaritan's Purse. IMF, International Medical Corps, they coordinated with the community health aspect. And so they set up and securing what if clinics had some type of functionality, then they helped with securing supplies and helping with workforce there. One of the things too was they also set up tents in the eastern part of the island to help out with seeing non-communicable diseases there too. They also helped in WASH in helping us get portable water because like I stated before, even though we may not have challenges with the contaminated water, because most people were advised not to use it, our challenge was that our entire water table was inundated with salt water. And so it was, like I said, it took us 2 years to be able to actually use our tap water properly. And so that was a significant challenge. So they helped a lot with us getting portable water.
That's excellent. And thank you so much for sharing those very personal experiences with the entire group today. Dr. Elizabeth has posted a question and she asks, what is the relationship between the overall outcomes of the different hurricanes and the level of education, financial capabilities, and each individual's preparedness?
So there's a direct correlation definitely when it comes to finance. So I have to finish my study, but looking at the different disasters that occurred in the region, there's a direct correlation between a nation's GDP and how well they respond to a disaster. And that coincides with a lot of studies. Education as well, finance, all of those. So the more, simply put, the more educated you are about a disaster, the more resources you are able to access, the likelihood of you faring well or surviving a disaster is improved. And so that's why I stress that the way the community responds to a disaster, how well it responds is how well its most vulnerable response. And so that's why it's important that's why I keep stressing equity in our response.
Thank you so much. So we do have a question that's posted in Spanish. So if Amado could just come on and do the full translation, I would appreciate that very much. But while he does come on, Greg, who is a pharmacist who is a part of the WADM as well, says, "Hi, I'm Greg from Wisconsin. From a pharmacy side and a general healthcare side, what are the top 3 actionable things that would help to improve outcomes during and after hurricanes?"
So as far as pharmacy or on the whole, so for our challenge was we lost we lost a good bit of our stock because my hospital is one floor. And so our flood waters got up to 4 to 5 feet. So we lost a good bit of our stock. So what it would mean, and it's a challenge for being on an island, is trying to figure out where you can secure your stock safely away from floods. And that it's also climate protected as well, so that if you have a stock supply, you can access it in the time of need. One of the things that I will say, when we had persons that responded to us after Dorian, one of the challenges that I had was that persons came and they brought medication, but understanding, and there's some things when you go to support countries with humanitarian aid, especially when it comes to medication. One thing that I like, I know you feel like you got to grip up everything and run with it. The challenge is that for us in pharmacy, everything, even though, yes, our pharmacy was gone, we still had our pharmacist. So whatever medications that come to us still have to go through the pharmacy. So anything that was loose or was not properly labeled, we thank persons for giving it, but we could not give that to patients. So that's the one thing that I would say, if anybody who is interested in doing humanitarian expeditions and deployments, especially with pharmacy, that's one aspect to look into.
Very interesting. Very, very interesting. And I can see the logistic issues with that. So Sandra is coming on to translate. But I did access Google Translate in the interim.
Whenever
I'm
you want.
available if you want.
Amado. Okay,
I
fantastic.
I'm here.
I apologize for my ignorance. Please go ahead.
Yes, the question disappeared.
Sorry,
But
I
it was a
just
question.
reposted it. Sorry, it's in
Oh,
the
you
chat.
did. Okay.
It's in the
Okay.
chat. Sorry,
Give me a second.
and it's in English. Sorry.
Oh, okay. So greetings from Dominican Republic. I think this was Dr. Blanco. I'd like to know what protocol you have for collaborating with nearby Caribbean countries to activate emergency plans and receive mutual aid.
Okay, so one of the organizations that I had mentioned is SEDEMA, and that's the Caribbean Disaster Emergency Management Agency. And that's like a governing body that incorporates all CARICOM or Caribbean nations, English speaking. I don't want to overstep because there might be some people from Spanish speaking and French speaking that may be involved. But basically, that is the governing body. And so they deal with like mutual aid agreements with countries that are involved. So let's say something happens, so if something was to happen in Dominica, our call would probably go out to SEDEMA the same way it would go out to WHO. And they would discuss the challenges and see what they had available from regional partnerships to see how best they could assist. So I would say it's SEDEMA is who is our regional governing body when it comes to disaster management and EOCs, activating EOCs.
Yeah, and I think that's actually a really good response to that, Latoya. My question actually was, well, my other question, because Sedima does a lot of the coordination, but do you think that the health representation in Sedima and just by extension most disaster preparedness groups, do you think the focus on health is what it should be, or is the voice of health strong enough?
Personally, I think it could be stronger. That's why I advocate for us who are in positions, especially of leadership. If you have the ear of your government official, your Ministry of Health, push your Minister of Health or your departmental health representative, whoever it is, to try and have the ear of the government, especially when it comes to disaster management, on focusing on health. I think they're coming. I think they're starting to come around, realizing that health does need to be at the table. But I don't think we're completely there yet. They're recognizing it. We're getting there.
I agree with you. So somebody is asking for your email address as well. So if you'd be kind enough to share at the end, that would be helpful.
Sure.
And then someone is asking, based on your last impact of Hurricane Dorian at your hospital, what would be your recommendations to mitigate in terms of the action plan?
Well, the challenge is with my hospital. Unfortunately, I say this as me. When we say we need to build back better, some things, and it had to do with the fact timing as well. Hurricane season happens every year. So when you don't have a hospital, the impetus is hurry up and get you in a hospital. And so to actually build back to be a completely climate resilient, not necessarily. So I would say our focus now and to mitigate is trying to see what we can retrofit in the structure that we have now to make it climate resilient. So ensuring that our shutters, that we have proper hurricane shutters, trying to see how we could invest in ensuring that, yes, we have generators, but making sure that there's solar power with backup batteries. Because we've already known, we dealt with the flooding and we dealt with the power loss. I'm happy to say that at least when they did rebuild stuff, they made sure that if the generators, they made sure build them up higher so that at least they're 4 or 5 feet off the ground, because realized that flooding was a significant challenge. So yeah, the government is building a new Freeport campus that is supposed to be a new medical center that is supposed to encompass clinics as well as a hospital. And I'm told that is being built climate resilient. I have not been at the table for that as yet, though.
But it's a very interesting question, Latoya. For those of us from the Caribbean, the infrastructure in many of the islands I've been to are a bit aged and not built, not designed or built in an era where sustainability was a thing or preparedness was a thing. And therefore, to speak to your point, it's something that we should have as part of the discussions. How do we protect ourselves and by extension, protect continuity of service in cases of disaster? So point very well taken and a very interesting discussion coming out of it. We do have just a couple minutes and I will give you closing words. But just one more thing I wanted to ask, if you'll allow me. You mentioned risk communication in disasters, and that's something that I feel strongly about as a very powerful tool. Can you tell me if or your experience on if the providers in the Caribbean you feel are adequately prepared to risk communicate during disasters?
I think that's where I think we need training on, and that's why I went into disaster medicine. I think us in the Bahamas, we know how to talk about hurricane preparedness because it happens every year. We're used to that. But when it comes to other disasters, how to discuss risk, that's where I think we need training on. We know the clinical impacts because we see it, but it's making sure we link it to climate change and so that we get our patients to link it to climate change as well.
Yeah, and for those of us on LinkedIn, I did notice Professor Siotone posted up something on the hospital indices for disaster preparedness, and I do think that is something that we should all take heed of. I'll give you 1 minute to close. Any closing thoughts or I know you've gone through a great amount of detail, but one key take-home point that you would want everybody to leave with today.
I would say if you are in health and you have a position of advocacy, my key point is to say whoever's doing, like again, reiterate, whoever's doing climate change in your country, who sits at the negotiating table, make sure that you stress upon them, find out how is health in that negotiation, and you negotiate for health. And my point is don't go for mitigation. Mitigation is reducing carbon input. We make less than 1%. Yes, other people got to mitigate. Go for adaptation and loss and damage. Adaptation so that you can strengthen your infrastructure, and loss and damages so that the persons who are the big emitters pay for our adaptation.
Agreed. And thank you so much. So on behalf of the Latin American and Caribbean chapter of WADM, Latoya, I thank you sincerely for making the time. I understand what a busy schedule you run, both clinically and administratively. It means a lot to all of us that you've taken the time to prepare such a comprehensive discussion. And that is clearly evidenced by the discussion that has come out of your presentation. Thank you for all in attendance this evening from all across the world. I've seen people saying that they're from Italy, so we have people from Europe, from Africa, from Australia. I'm not quite sure what the time zones look like, but I appreciate each and every one of you for logging in today. None of these webinars would be possible without our friend Andrew, who's always behind the scenes pushing us through and making sure we are kept in line. So Andrew, on behalf of all of us, I thank you very much. And of course, from my great colleagues, Sandra and Alejandro, we appreciate everyone, and thanks again. We look forward to seeing you all at our future webinars, which will be advertised on all of our social media channels. And I look forward to meeting each and every one of you all in time. Thank you and good evening.